Is really a shift in how we approach lung cancer, meaning that we see immunotherapy approaches in much earlier lines of therapy than what we've been used to so far. I could mention the KEYNOTE-24 trial that's presented this afternoon at the Presidential Symposium. A major impact on therapy from now on will be testing our patients up front for PD-L1 expression, and if they have a high expression level, they will get immune checkpoint inhibitors monotherapy instead of chemotherapy, and that's a big step forward. Dr. Barlesi from Marseille, he presented the results of the OAK study, which is a study of atezolizumab compared with standard chemotherapy and second, third line setting, and again showed an improvement in progression-free survival and overall survival for atezolizumab compared to chemotherapy. So this replicates what we know from the KEYNOTE-10 trial with pembrolizumab and what we know from the CheckMate 17 and 57 trials with nivolumab. One interesting point in this is that we don't need the assay of PD-L1 expression. Hazard ratio is just as good in PD-L1 non-expressors than in PD-L1 expressors. Also, histology doesn't matter. There was actually very impressive data. I'm speaking of the magnitude of difference he showed between the two arms. So one arm, platinum pemetrexed compared with platinum pemetrexed and pembrolizumab. So a major difference in response rate. What's already quite a surprise, because in unselected patients, you wouldn't expect actually an immune checkpoint inhibitor to crack the ceiling of about 20% response rate, and yet it's much higher than that, and especially in high expressors. He will show this this afternoon. Also, progression-free survival is massively prolonged. So he cautioned us, let's wait for the phase 3 data, but it looks extremely promising. So the field is changing very quickly. There was more in the field of targeted therapy, addressing therapy of ALK-rearranged non-small cell lung cancer patients. In this setting, we already know that second-generation inhibitors like alectinib or ceritinib, which was the drug tested in the ASCENT-5 trial and compared with chemotherapy, actually provide an improvement in response rate and progression-free survival compared with chemotherapy and in the second-line setting and third-line setting. What the real issue is, in my view, is what we should use in first line, because there are major issues with crizotinib in the sense that many patients progress in the brain, even if they have extracranial disease control. And this is something we like to see as little of as possible. We already know from the Japanese part of the ALEX trial, we compared alectinib to crizotinib in first line, that alectinib actually is the better drug. And I think we'll have to wait for the final results of the ALEX trial, but this will change again how we approach the first line treatment. So crizotinib will be out, I expect, and alectinib will be our first line choice. I think one major issue that we've heard very little of is the issue of biomarkers. We have no good biomarkers that are actually of any help in selecting individual patients for an optimal immunotherapy strategy. We are stuck with the good old PD-L1 immunohistochemistry, which is a very crude tool to enrich patients' populations for trials. It's now a decision factor in Firstline, but it's really something that leaves much to be desired.